thank you for this invitation and for having me here to talk about the applicability of SyMRI or synthetic MRI for routine imaging purposes. So this is an area we're going to cover within this presentation, and of course for research purposes. So I'm currently working at the Division of Neuroradiology and Musculoskeletal Radiology of the Medical University of Vienna. And we introduced SyMRI or synthetic MRI in 2017 in our standard protocol for neonatal imaging. So we'll take a look at some neonatal cases afterwards. And of course, our initial experience was primarily focused on research. So between 2017 and 2024, we focused on research purposes before we started applying SyMRI or synthetic imaging for routine imaging purposes. And we integrated the system into our PACS in 2025. And now we also use it clinically. So which sequences do we use for synthetic imaging purposes? So first of all, the mainstay of SyMRI, or the sequence I'm personally associating with synthetic imaging, is the multidynamic multi-echo sequence, which is a 2D sequence that runs on a 1.5 Tesla machine and a 3 Tesla machine at our institution. But apart from that, we are happy to use a 3D sequence, the 3D class sequence that is available for 3 Tesla machines, and we also integrated this sequence to our protocols. And the important thing is that we integrated this system via a fully automatic post-processing pipeline to our PACS system. So we acquire these sequences. When they are transferred to the PACS system, there is a fully automatic post-processing process that generates multiple contrasts based on one of these single sequence acquisitions, and all the different contrasts are transferred into the PACS system. And in case, with regard to the 3D class sequence, we do not only acquire 2D data, we acquire 3D data, so we get different contrasts, multiple contrasts based on one single sequence acquisition in multiple planes. So now let's have a look at some technical issues or some technical things. So this system, you can also see our scanner. This is the working horse at our department. We are also using in the night shifts. This is a 1.5 Tesla Philips Ingenia, and we acquire MDME data in 5.5 minutes acquisition time. Now let's have a look at the 3 Tesla machine. This is the 3 Tesla Philips Ingenia Elition scanner, where we run the multidynamic multi-echo sequence, around 6 minutes and 15 seconds acquisition time. So we use this sequence on this scanner, for instance, in our standard protocol in multiple sclerosis patients. We use a 3 Tesla Siemens magnetum Vida scanner, where we use the multidynamic multi-echo sequence. And as you can see, we use or acquire a bit thinner slices in this on this scanner, because we also use this scanner for pre-surgical planning in pituitary adenomas. We'll also have a look at some cases in this regard. And of course, the 3D colors sequence, which runs on our 3 Tesla machine, where we are able to acquire data within 4 minutes and 20 seconds acquisition time, which is of course clinically acceptable imaging time, especially when you take into account that we acquire multiple contrasts and multiple planes. So this is really impressive, I would say. So now let's talk about some research aspects. And as mentioned, we have a strong focus at our department on fetal imaging and neonatal imaging. And also, so let's say perinatal imaging is one of our focuses. And as mentioned, the first cohort or patients where we integrated the multidynamic multi-echo sequence were neonates. And at our institution, it's common practice to image former extremely preterm-born neonates, which means born prior to 28 weeks of gestation at term equivalent age. And we had the idea that this technique, this novel technique, could be beneficial when assessing ongoing myelination processes. And I'd like to show you some research cases now or some publications on this topic. So what you can see right here is the current gold standard for assessing myelination. This is a T1 weighted sequence. On the left side, you can see a term-born neonate, and on the right side, a former extremely preterm-born neonate born 24+4. And imaging was performed, as mentioned, as a routine imaging performance at term equivalent age. And when we now assess ongoing myelination processes in these infants, you can see in both cases, in the posterior limb of the internal capsule, there is a hyperintense signal, which indicates the presence of myelin. And I would say this hyperintensity is present in the term-born neonate, but also in the former extremely preterm-born neonate. And especially when not having a companion case or a case adjacent to the former preterm-born neonate, we would not report on a significant delay of myelination. Now let's have a look at T1 mapping, which is one of the color maps we can generate based on a multidynamic multi-echo sequence or on SyMRI based data. What you can see now is there is this bluish color coding in the posterior limb of the internal capsule in the term-born neonate, which indicates the presence of myelin due to myelin-induced relaxation time shortening. So the voxels are color-coded according to their relaxation times. Myelin leads to relaxation time shortening. So this proves the presence of myelin. When we now take a look at the former preterm-born neonate imaged at term equivalent age, you can see there is absence of these bluish color codings, which indicates that there is myelination delay. And of course, this is much easier to assess ongoing myelination processes, potential myelination delay in these infants or in these patients when having a color coding. So this is really helpful for assessing ongoing brain maturation. So now maybe you ask the question, this is of interest, but however, does it really impact clinical management of these cases? And there's another article we published in 2024. At our institution, it's routinely performed to follow up these former extremely preterm neonates by cognitive and motor testing. 1 year, 2 years, 3 years, and 5 years after birth. And we now go ahead and correlate these outcome data with our myelin metrics collected at term equivalent age. So what you can see here is the first article on this topic or on this series, let's say. We collected quantitative measurements such as relaxation times, proton density values, but also diffusion tensor data, such as ADC and fractional anisotropy values. And you can see that there is a correlation between these myelin metrics collected at term equivalent age and future outcomes. So therefore, this may help us in the future to identify neonates or infants in need for more intensified support throughout their development. So maybe you ask the question, bluish color codings and relaxation time shortenings, we know that this is associated with ongoing myelination processes, but how do they prove that this is really myelin they are looking on? And of course, we also aim or made an attempt to prove that. And as mentioned at our institution, we do a lot of fetal imaging. Of course, fetal imaging in vivo, in utero. However, if there is the case of a medically indicated and induced abortion, we also aim to image these fetuses that received ante-mortem or in vivo MRI. We also aim to image them post-mortem. And in these cases, it's also possible sometimes to get histological correlations for our MR studies. And this is what is presented on this slide. You can see in the upper row, quite young fetus. Imaging was performed at week 24+1. And on the right side, you can see a myelin basic protein staining. So this is considered a highly sensitive staining method to prove that there is myelin. And myelin would be appreciated as a brownish staining, which is absent in the upper case. And when we now take a look at the mapping techniques, on the left side, you can see a SyMRI map, a T1 map, and in the middle, a magnetic resonance fingerprinting T1 map. And on these mapping data, MR data, there is no bluish color coding, which indicates typically the presence of myelination. And when we now take a look at the MVP or myelin basic protein staining, you can see there is absence of myelin. When we now take a look at the bottom row, you can see a more advanced stage of gestation, so week 32 plus 1 days. And when we take a look at the myelin basic protein staining, you can see there is a brownish staining in early myelinating fiber tracts that travel through the brainstem. So this is the level of the medulla oblongata. And when we now take a look at the mapping data, on the left side SyMRI and in the middle MR fingerprinting, you can see there is myelin-induced relaxation time shortening presented or depicted by this bluish color codings. So this proves that this technique is really sensitive to ongoing and really, really early myelination states. And of course, we made an attempt to apply this technique also in vivo and in utero, and we already published an article on that in a series of 12 cases. So of course there is fetal movement, so it will take some technical optimizations to make it run for routine fetal imaging. But however, the technique holds the potential to be used in these fragile patients and at these very early stages of myelination. And this is really helpful because currently the current gold standard for assessing myelin is the T1 weighted sequence, and as demonstrated in this presentation, there are some limitations. So now let's go ahead and take a look at some clinical data and some clinical cases. And as mentioned, we integrated the multidynamic multi-echo sequence and color sequence, so SyMRI, into our clinical workflow. And what you can see right here is the brain of an 88-year-old patient who presented with choreatic movements. And the neurologists suspected some minor stroke within the circuit of the basal ganglia that may cause these choreatic movements. And in this case, in this special case, it's important to mention this patient had already received CCT and CT angiography. And we performed MRI to detect whether there is a minor stroke. On the left side, you can see the diffusion-weighted sequence. There is no diffusion restriction present. And when we take a look at the T2 flare sequence, there is also nothing on which proves or which explains these choreatic movements. And it was at the end of last year, I had the idea to integrate our MDME sequence, SyMRI sequence, to our stroke protocol. So the stroke protocol at our institution consists of a 3D time-of-flight angiography, which was not run in this case because we already had CTA, a diffusion-weighted imaging sequence, and a T2 flare sequence. And we added the MDME sequence, and sometimes we also remove the flare sequence and just do the MDMA sequence. And what is interesting in this case, this is a T1 weighted flare sequence based on SyMRI. And what you can see here is hyperintensity in the basal ganglia on the left side. And this is in keeping or a typical feature of diabetic encephalopathy, which also explains these choreatic movements. And when we switch back to the flare sequence, which would be the anatomical sequence, let's say, in the stroke protocol, there is no evidence of diabetic encephalopathy on this imaging data. So therefore, this is a nice example of how MDME-based imaging may enhance such protocols and how it may help in the clinical routine. So now let's have a look at another case. So at our institution, we do a lot of functional imaging. So prior to neurosurgery, and usually these are patients suffering from epilepsy and due to tumor lesions or any other processes going on in the temporal lobe. What you can see here, for example, is a patient suffering from hippocampal sclerosis on the left side. This is a memory paradigm, and you can see that there is organization toward the right side of the brain. So you see activity in the right mesial temporal lobe during this memory task, but absence of such activation patterns on the contralateral side. And as mentioned, usually we already have structural imaging to check where is the lesion, where are our activity patterns in relation to these lesions. So therefore, we use a protocol consisting of a T1 3D sequence, usually EPI sequences for functional tasks, and a diffusion tensor imaging sequence. And last year, we also added the 3D color sequence to this protocol. So now let's have a look at this case. So this is a 56-year-old patient. There are seizures that originate from the right frontal lobe, and functional MRI was requested on the referral. However, in this case, we did not have structural imaging available. Sometimes this happens that we do not have the prior investigation. But however, it's very important to know where the lesion is, where are the activity patterns. This is crucial for the neurosurgeon to know. I will tell you that on this slide, there is pathology, or on these levels of these imaging data, the pathology is depicted, but however, based on a T1 sequence, it's not that easy to catch. Now let's have a look at the benefit of the color sequence in this case. You can see there is thickening of the gray matter, white matter interface in the right frontal lobe. And this is in keeping with a low-grade glioma. And this is, of course, helpful to get a lot of information based on a one single sequence acquisition, and is helpful when interpreting functional MRI data, especially if there is no prior imaging data available. So this nicely proves that this sequence enhances such protocols within a clinically acceptable examination time. So we all know the problems or the issues with children of younger age or infants. It's sometimes not that easy to get MR data in these children. And this is such a case. This is a 3-year-old boy, and there is seizures present, there is headache, and the frequency of the seizures increased. And we already had CT data available that revealed some cystic lesions in the left hemisphere. But however, we aimed to do MRI in anesthesia, but however, the parents refused to do so. So therefore, we made an attempt to acquire MR data without sedation, without anesthesia. So therefore, we need to shorten the protocol as much as possible. And in this case, we performed, it was in a night shift. It was a case in a night shift. We performed a T2 sequence, and we performed an MDME sequence. And of course, we see there is something going on in the left hemisphere, but however, it's not that easy to further characterize these lesions. So now let's have a look at this imaging acquisition. You can see on the right side of this slide, the MDME-based double inversion recovery contrast, where white matter is suppressed, but also CSF. And you can see at certain areas, there is some hyperintensity surrounding these cystic lesions, which is one of the specific signs, which is called the bright rim sign, which is highly suspicious for the presence of DNET, which of course explains these epileptic fits. And this case nicely proves how such a sequence may enhance the protocols and help us to further characterize lesions that are hard to interpret based on single sequence acquisitions or on CT-based imaging data. Okay, now let's have a look at one case with regard to pre-surgical planning. So as mentioned, we do imaging for the neurosurgeons prior to surgery for them to have their surgery planned appropriately. And usually we just perform a T1 sequence in all 3 planes after gadolinium. In 2021-2022, we added a multidynamic multi-echo sequence to this protocol prior to the administration of contrast agent. And why is this helpful? We also published an article on this topic in 2024. When we use this sequence and we take measurements in the lesions, so the T1 relaxation times, T2 relaxation times, proton density metrics, it may help us to predict and to tell the neurosurgeon how the consistency of these lesions will be organized. And this is, of course, helpful. So in pituitary adenomas, it's not uncommon that these lesions are of high water content and are easily removed. However, sometimes in around 20% of the cases, there are fibromatous components within the lesion, which makes them really hard to resect. And of course, this is helpful for the neurosurgeons to know prior to surgery how these lesions are with regard to the consistency. And we're currently working on that to establish this sequence as a standard sequence for pre-surgical planning at our institution. So thank you very much. This is my last slide, which shows some titles of articles we also have published on SyMRI, but however are not integrated in this presentation. And on the lower left, you can see my contact details. So you can, of course, contact me if you have any questions about this topic and about this technique. And so thank you very much. Florian, I think I will share the screen or I will give you the rights to share your screen again.
Yeah. Awesome. So first of all, thank you very much for the presentation and your valued clinical insights on what you do at AKH Vienna. So very interesting. So we have a couple of minutes left for, let me quickly, first of all, share my screen here again. So I wanted to share this screen. So this one. Screen one. Okay, so again, thank you for your presentation and the clinical insights. So as we have a couple of minutes left, I would actually go through the Q&A. So we have a couple of questions, but due to the time, we maybe can do one or two. But for the audience, as you know, once you have questions, once you raise question, but it's not answered live, so we are going to collect all of them, send them to Dr. Schmidbauer to make him answer them questions. We're going to collect them in a Q&A and going to send out afterwards. So the first question we have talking about the post-processing is, so how long does it actually in average take to do the post-processing?
Okay, so this is an important question. It works really fast. So we acquire the data on our scanner. We send the data into our PACS system, and it takes around 10 minutes, I would say, a maximum of 15 minutes to get all the contrasts fully post-processed within the PACS available. So this is, of course, also a clinically acceptable time frame, waiting 15 minutes to have a bunch of multiple contrasts available. Yes. And it's also the most important thing when we talk about the 2D sequence. It's just one plane. Of course, it's acceptable, but the time frame is the same for the 3D sequence, and this is I think, for a clinical radiological work, excellent. Yeah. And when we just talk about the post-processing directly on the workstations, you send the data into the workstations. It takes a few minutes, and when you do the post-processing on your own on the software, it takes around, I think, 60 seconds, and that's it's done.
Awesome. Thank you very much. And maybe one more question. We have 1 minute to go. So you were talking about the gadolinium usage. So this is might be interesting, is if the amount of gadolinium used can be reduced, or is it actually or completely being done differently or reduced?
So the first article, I think we were one of the first who published articles on SyMRI based sequences that were contrast enhanced. And for this study, which was published in 2024, it was the one with the pituitary adenomas. There's also a result regarding the sensitivity of post-contrast MDME sequences. We used the standard amount of 7.5 milliliters Gardovist, so we did not reduce it. But we are currently working on a project with Professor Basalamah, who is an expert in the field of liver imaging. And he did a lot of research on how to reduce the dose of Primovist and how to use it in combination with other agents to get excellent results and reduce the dosage. And this is something we aim to do with SyMRI too. So this is a project which is going on currently.
That sounds good, especially for children. I think this is worth to do, right?
Of course.
So just to be respectful of time, as we are already over the time of the planned webinar, I would like to again thank you, Dr. Schmidbauer, to taking the time to run the webinar, to give the clinical insights for what you do. But as well, what I would like, before we going to end, I would like to highlight one thing. As you already maybe know, this is going to be a webinar series, meaning we don't stop here. So the next session is coming up next Tuesday at 10:30 Central European Time with Professor Granberg from the Karolinska Institute talking about the qMRI and CDSI solution. So we are really looking forward to that. And with that said, I just can say enjoy the rest of your day. We hope to see all of you again back to the session next Tuesday. Thank you, Dr. Schmidbauer, to taking the time and for your presentation. So enjoy the rest of the day, everyone. Thank you.